cisplatin-based chemotherapy has really been the backbone of neoadjuvant treatment for patients with muscle-invasive bladder cancer. And ever since the SWOG 8710 study that was published in 2003 in the New England Journal of Medicine, that has been adopted as the standard of care for folks who are eligible for cisplatin treatment. And the impetus for incorporating neoadjuvant IO into the space is really twofold. Number one, because of all of the efficacy signals that we're seeing in the metastatic setting with immune checkpoint blockade, there really is this push to understand whether the immune checkpoint blockers can be also used in the neoadjuvant setting as an efficacious way of treating bladder cancer. But secondly, in those folks who are ineligible for cisplatin-based chemotherapy in the neoadjuvant setting, they really don't have any systemic treatment options. And we know that radical cystectomy is not sufficient in controlling their disease. And hence there's this unmet clinical need to develop efficacious systemic treatments prior to the onset of surgery to control the micrometastatic disease. And hence immune checkpoint blockade is a natural fit for those patient populations. So armed with those two questions, we really wanted to look retrospectively at the comparative effectiveness of chemotherapy versus IO in the neoadjuvant setting. This is a collaborative study between two centers, the Moffitt Cancer Center in Tampa, Florida, as well as San Raffaele Cancer Center in Milan, Italy, and a collaboration between colleagues and great friends, myself, Dr. Phil Spies here at Moffitt Cancer Center, and Dr. Andrea Necchi at San Raffaele, where we compared a retrospective cohort of muscle-invasive bladder cancer patients who were treated either with upfront radical cystectomy, so i.e. those patients who were ineligible for chemotherapy and then went on to upfront cystectomy, or those patients who were treated with neoadjuvant cisplatin-based chemotherapy here at the Moffitt Cancer Center, versus those patients who were enrolled onto the PURE-01 trial, which was conducted exclusively in Milan with 157 patients. And out of those 157, there were some patients with who fit the cisplatin ineligible criteria, and then there were patients who were cisplatin eligible. And I should point out that the PURE-01 trial is the only trial in which the cisplatin eligible patients were also enrolled on for neoadjuvant pembrolizumab or immune checkpoint blockade treatment. So from the overall cohort of 955, we included 604 patients, 391 of whom were cisplatin eligible and 213 were ineligible. And out of the eligible cohort, 273, again, were treated with neoadjuvant cisplatin chemotherapy here at Moffitt, and 118 were treated in Italy with neoadjuvant pembro, whereas for the cisplatin ineligible patients, there were 185 who underwent upfront radical cystectomy at Moffitt and 28 who were treated with neoadjuvant pembro, followed by radical cystectomy in Italy. The primary endpoint from this study is event-free survival is characterized by disease recurrence or death of any cause. And as a secondary endpoint, we knew that the cohorts that were included from Moffitt and also onto the PURE-01 trial, because it was done in the setting of a clinical trial, were most likely going to be very heterogeneous, meaning that in the real world, there are a lot of patients who have a ton of medical comorbidities that are still treated with cisplatin-based chemotherapy, or with chemotherapy or upfront cystectomy, whereas there are those patients with higher comorbidities are most likely excluded from the trial because of various reasons. We also wanted to perform a inverse probability weighting to homogenize the study cohort so that we can understand within the similar patient population how effective chemotherapy or upfront cystectomy is versus pembro.